Hi, my name's Ian Williams. I've been asked to talk to you about GRADE and how that relates to the BHIVA guidelines. And so GRADE stands for Grades of Recommendation, Assessment, Development and Evaluation. It's a methodology of assessment and recommendation for guidelines that have been adopted worldwide, including the WHO, as well as BHIVA, as well as NICE, as many other organizations throughout the world. So it's become the system that is used most widely. So before we start looking at GRADE, I just want to make you aware of the Guideline Development Manual. This gives you an overview of all the steps that are required when producing guidelines, from establishing the committee right through to developing the questions, developing the assessment of the doing GRADE, through to implementation and assessment and educational resources. So I would ask you to be familiar with the development manual, because most of the information you require to understand the steps of the development guidelines are in there. And the website is on the bottom of the slide. So if we just quickly look at the main steps for guideline development. So the first step is define the scope and purpose of a guideline. So what is the main purpose? The scope is how wide those guidelines are going to be and who are they targeted to. But the two first steps, once you've decided the scope and purpose of a particular guideline, whether that's antiretroviral therapy or HIV testing or pediatric issues, you then need to define the questions you're asking about your intervention or which is appropriate to the topic. And you develop your PICO framework, you develop your outcomes, and then you perform your systematic review. So if we just quickly look at the PICO framework, so it's important to select the topics that you want to ask questions about and define the questions appropriate for those topics. So it may well be, is drug A better than drug B? Or is, in this situation, treatment regimen A better than treatment regimen B? Okay, but it's or compared to standard of care. And for each of those questions, you need to develop the PICO criteria, which is your population in which the intervention is in. The intervention itself, define what that intervention is. Define the comparator, which is largely would be your standard of care. And also, most importantly, you need to define the outcomes. So the outcomes are really important in GRADE, because GRADE, it's vital to define the outcomes for the quality assessment evidence and inform the recommendation. So there may be multiple different outcomes that are important, and some may be related to patient biological outcomes like viral load, other may be related to patient experience, side effects, and so but you need to define which outcomes will influence your recommendation when it comes to assessing the evidence and defining your recommendation. And you need to rank those outcomes according to whether they're critically important for decision making, important but not critical for decision making, or not important for decision making. Okay, and we'll see why that's important, because the quality of evidence for a critical important outcome will carry much more weight than something that's either important or not important for decision making. So defining the outcomes that are important for decision making at the start of your process is very important. You shouldn't do it at the end. If you look at your evidence and say, I'm going to look at this outcome because I think this is best to what I think should happen, that's not the right way forward. You need to define it, and all the guideline committees certainly would have looked at the outcomes and then ranked them accordingly with what is critically important. And for each of the outcomes, what GRADE does, formal GRADE, we don't have formal GRADE for everything we look at, but is we generate an estimate of effect for each of those outcomes. So that's basically in terms of defining your PICO criteria and defining your outcomes. You then develop your literature research, you formulate your search strategy and protocol. So that means you define your databases, you define your date parameters, you look at the study design. Is it all going to be randomized controlled trials, or are you going to put in cohort studies? Are you going to include conference abstracts? All of that clearly will have an effect in terms of what you find. And at the end of that, you will then have to search and sift and select studies which meet your selection criteria according to what you're trying to look at. And so you end up, so your search strategy will identify multiple different studies, and then you whittle those down to a few. So the next part really is to evaluate and grade the quality of evidence. So, and then once you've evaluated and graded the quality of evidence, it's then about developing and grading your strength of recommendation with regard to that evidence. So in a formal process with grade, you need to critically appraise the papers. So if you look at some of the appendices that are on the BHIVA website for some of the ART guidelines, you'll see in the evidence tables there's a critical appraisal of some of the papers, which goes through and identifies issues regard to study limitations, the indirectness of comparison, imprecision and such like, in terms of what are the main things that may be a problem with that particular study. You then, for each outcome, you then will estimate the size or magnitude of effect for each outcome. So if it's for viral load, it's a proportion below 50 at a certain period of time, or if it's an adverse event, serious adverse event, it's the number of serious adverse events, or if it's something like a particular adverse event, it's the incidence of that particular adverse event. And you look to see whether there's a difference in that effect for each outcome, and whether that difference in effect is clinically important. So there may well be something that's different, and it's significantly different, but it may not be clinically important. And then based on that, you can then develop and grade your strength of recommendations with an outline of supporting rationale, which you then put into your guidelines. So grade is grading a recommendation, assessment, development and evaluation. It's an approach to grading evidence that moves away from initial reliance on the study design. So we can all look at a study and say there are severe limitations to the study. But you can, as we'll see, make recommendations which are strong recommendations but based on weak evidence. Or you can make weak recommendations based on strong evidence. And what you need to do is look across the overall quality of evidence across all your outcomes, but prioritizing those that are critical, that have been defined as critical, prior to you defining your, before you did your literature research. So a sense of saying that if there may well be, some people may feel that virological failure is much more critical than virological suppression, or serious adverse events may be more important than anything, right? So it's important to grade that at that point in time. So the grading of the recommendation has two components. It has a quality of evidence component, which is graded A to D, and that's the extent to which the confidence in estimates of the effect are adequate to support the decision. So based on your critical appraisal, based on the estimate of effect, you can determine whether that is high quality, moderate quality, low quality, or very low quality evidence. And you can define that. Once you've defined your evidence across each outcome, how you grade the evidence may then depend on how you've graded your outcomes with regard to critical, important, or not important. Because clearly, if you have very good evidence for an outcome that is not particularly important for clinical decision making, and that is graded as very good evidence, then that may not be so important if you have evidence for a critical outcome that is graded as very low quality evidence, but it's a critical evidence with regard to your recommendation and outcome. And so the critical outcomes, the quality of evidence of the critical outcomes always outweigh everything else. Now then, when you then look at the strength of recommendation, you can either have strong or weak. And the recommendations should be specific and actionable concerning a target population and a specific intervention strategy. So we recommend or we suggest. Or we recommend against or we suggest. So if we go back to the quality of evidence, more concentrate on the quality of evidence first. As I say, you first of all have the critical appraisal of papers. You estimate the size and magnitude of effect for each outcome using forest plots. And you rate the quality of evidence for each outcome across studies. Now, A rating is modified downwards if there are study limitations such as loss to follow-up, or it's not blinded, or those sort of major study limitations in terms of, or the study was ended prematurely for various reasons. Imprecision would be if your confidence limits are quite large. So your estimate effect is really, you can't really be very precise in terms of magnitude of that effect. Inconsistency of results, it would be if there is variable results across different trials, okay, in terms of, and that would be. Indirectness of evidence is where you clearly don't have, every trial doesn't compare one intervention to the same standard intervention. So you may have an intervention which is compared to drug A, but drug C is only compared to drug B, so you may then have to compare A and B and then C to B. So there are, so that's the way you modify it, and the rating can be modified upwards if it's a large magnitude effect. If there are no confounders or confounders that might minimize the effect. So this is sort of, so things like randomized controlled trials start with a high rating, observational studies will start with a low rating, and the final rating quality of each outcome is either high, moderate, low, or very low. So, and then what you then do is comprise evidence tables, which basically has the critical appraisal of each study. It has your forest plots, and then it has a summary of findings tables, which basically for each outcome, you have assessed the quality of evidence, you've assessed the magnitude of effect, you've graded it according to what the quality is, and you've said whether this outcome is critical or not. Now, we don't clearly do this for every question that we pose in guidelines, but I'm only going through this as really to give an understanding of the principles of grade, because we largely use the modified grade system, which I'll come on into a second. But if there are critical questions that you think might be controversial in guidelines and which there is sufficient evidence, then it might sometimes be worthwhile asking for a grade analysis in terms of defining your critical appraisal, the studies that you've picked, your outcomes and such like, and taking it out to the end of the analysis in terms, because actually if there's going to be discussion and controversy within a guideline committee, it sometimes helps to dissipate that completely because the evidence is in front of you in terms of the magnitude of effect and the quality. And so expert A may say, I disagree with that completely, and expert B say, well, I support it. But if you've got your summary findings tables that tell you what the quality is and what the magnitude of effect is, it becomes much easier to address those sort of issues. So this is a summary findings table, which was for PI monotherapy, and just really give you an example of a summary findings tables. So what you see here, you have the quality assessment, and so the number of studies in this analysis was 10. The design was all randomized controlled trials. There were serious limitations in some of the designs. There was no serious inconsistency, no serious indirectness, and no serious imprecision, and no other considerations within that trial. And then this is the magnitude of effect in terms of the PI monotherapy versus the control arm. And you can see that in the 44 fewer per thousand virological failures in the control arm versus the PI monotherapy arm. So this was ranked as moderate because there was limitations in terms of the serious limitation of design, and it's a critical outcome because this is virological suppression. And so this would be ranked as quality evidence B, and depending on how your other critical or quality is, it will be ranked as either will be ranked as a 1 if you make a strong recommendation against something. So that's how you'll find grade tables that will be presented. Again, we don't use that in the majority of decisions that we go through, but I think it's important to understand how grade is. This is what the basis on grade is. It's basically analysing or defining your outcomes, defining the quality, ranking those outcomes, and then defining what the quality of that evidence and whether they are important for decision making. You can do that whether you make, you have complete grade tables for everything. So strong recommendation or weak unconditional recommendation is determined by so it's not the strong or weak recommendation is not just determined by whether it's the quality of evidence, it's determined by other things. So you could have a strong recommendation but with weak evidence. So the other things you take into account when considering the strength of recommendation is not only the quality, but the balance between desirable and undesirable outcomes. So for example, and we'll come, I'll get an example later on, so you may have a drug that works very effectively, but has a very serious side effect profile, okay? And therefore you would have to decide is which of those preferences, or desirable and undesirable outcomes, is the balance should be. Should it favour the efficacy, or should it favour the tolerability? And this is important. The values and preferences are also important for the guideline committee because there will be community people, there'll be doctors, there'll be pharmacists, and they may well have different values and preferences in terms of their balance of desirable versus undesirable outcomes. So a community representative may decide that they put much more emphasis on side effects, okay? While the clinicians may say, no, it's a biological efficacy. And that's the way you try and take that into account. And then the resource use. This is where you can put something in with resource use. So you could, for example, decide that you've got very good evidence for intervention A, but the cost is prohibitive, and therefore you make it a weak recommendation because of resource use. So we don't formally use resource, but you can take that into account when considering your recommendations. And it can be two-directional, i.e. for or against a strategy. So strong is re-recommend. So that implies that most patients and clinicians should follow this course of action, but a small portion may not if there's a good rationale not to do so. A weaker conditional is that we suggest implies that many patients and clinicians would want to follow this strategy, but many would not, i.e. an alternative strategy may be reasonable depending on the patient's circumstances and wishes. Okay? So that's how you would define it. So I just want you to take, this is in the BHIVA 2015 guidelines. I just want to ask you to read the third agent, and I want you to see whether there's an error there in terms of how a recommendation has been graded. So we recommend therapy-naive individuals start combination ALT containing atazanavir, ritonavir, dolutegravir, dolutegravir, elbapixant, cobicistat, raltegravir, or rilpivirine as the third agent, graded 1A. We suggest that for the therapy-naive individuals, efavirenz is an acceptable alternative third agent, graded 1A. What's the problem? Absolutely. So the quality of evidence for efavirenz, I've got another one. The quality of evidence is very good, it's A, but because you've taken into account the side effect profile and the balance of outcomes in terms of what's preferable and what's not preferable, then when we say we suggest, that's always a 2. So that should be graded a 2A. Okay? So that just takes into account the fact that you feel that it's still acceptable treatment, but it's not what the majority of clinicians may not want to do that. Okay. Quick question, yes. Yeah, okay. So the strength of recommendation, really, or weak or conditional, and this is where there's often discussion, is determined by the quality of evidence, which is a formal process, the balance of desirable and undesirable outcomes, and that's where the decision about what's critical and what's not critical in terms of decision making really is very important to be had at the beginning, so that you don't suddenly have a whole lot of people at the end saying, well, I think this outcome is far more critical than this particular outcome in decision making. You've got to make that decision about your critical outcomes right at the beginning. You have to get agreement. You can't go back on it. That's the reason why it's important to do that. The values of preferences is also very important. And so these will define, maybe, decide whether it's a weak or it's a strong recommendation. So we don't clearly go through all of that process in defining sort of summary of findings tables. It's very work intensive, it's resource intensive, but I think it's sometimes worthwhile to do if there are controversial decisions that need to be made regarding guideline committees, which will then stand up for external critique, particularly if it relates to drug companies or other things or NHS England or such like. Then I think taking the time to do the formal analysis helps you. You've not made a decision or recommendation, you've based it on the evidence of across a whole range of outcomes. So, what the Appendix 7 is in the BHIVA Guidelines Manual, and there are in your handouts, there is a table of the summary of modified grade system, grades 1A to 2D. And in each of those, it will give you an indication of what a 1A recommendation should be, right? So I forgot to... Okay, all right, you don't have it, okay. It's in the, it's not in there. Okay, fine. I think you'll find that I've got copies. So 1A is a strong recommendation. It's high quality evidence. It benefits clearly outweigh risks and burdens or vice versa. It consists of evidence from well-performed randomized controlled trials or overwhelming evidence of some other form. And I think this is very important here, is that further research is unlikely to change our confidence in the estimate of effect or of benefit or risk. So if you think a trial has given you all the evidence you require and that further evidence is not going to change that estimate of effect, then that's strong evidence. That is strong quality evidence. And strong medications can apply to most patients in most circumstances without reservation. Clinicians should follow a strong recommendation unless there's clear rationale for an alternative approach. Now you'll see in the summary of modified grade system that if you go down to 2B, it'll give you evidence of what B evidence should be, or 2C, 1B and 1C should be, and then going down to what is 2A, 2B, 2C, and 2D. So I think if you take anything away from today, is an understanding of those particular grading systems, and in terms of how, if you graded something 2D, then go back and look what it says about 2D. Does that fit for what you've just decided to grade? So a 2D recommendation will be a weak recommendation. It's a very low quality evidence by the measures that we've looked at. It's uncertainty in the estimate of benefits, risks and burdens. Benefits may be closely balanced with risks and burdens. Evidence may be limited to case studies and expert judgment. Expert judgment is quality evidence D. It is not quality evidence A, quality evidence D. And very weak recommendation alternatives may equally be reasonable. Okay, so I think so look at that particular table, because it does give you a sort of sense of where you are when you make recommendations, because you won't have the summary findings tables for each particular recommendation or intervention you're going to be looking at. So I'm going to just go through a formal application of grade that we did in the 2012 guidelines, just to tell you how we arrived at our decision. Okay, so is PI monotherapy an appropriate treatment strategy for treatment-experienced patients on ALT with virological suppression? This was before the PIVOT study was reported. So that was the question. The population were patients who ALT experienced for more than 6 months. They were undetectable, less than 50, no previous PI resistance, so we defined the population. The intervention was PI ritonavir monotherapy. The comparator was standard triple therapy. We did a systematic review and RCTs were included in the literature search. The search period was defined, and we defined the databases, and we also included conference abstracts. So within this particular question and two others, we identified 489 studies that might be appropriate to this particular question. And they were then sifted down to identify 18 papers which identified 10 studies, 8 for lopinavir and 2 darunavir. And those were then critically appraised and placed in your in the grade tables. But we had also before then determined what our treatment outcomes were, and we had put a virological suppression, drug resistance. You may not put CD4 count in there at the moment, but clearly the virological resistance and virological suppression was key in terms of how we put down critical. Grade of 3 or 4 CNS disease or abnormal liver function tests were ranked lower. Not that they're not important, but they were not deemed to be critical to decision making. And we generated an estimate effect of the intervention for each outcome. So this is what you get in terms of the forest plot. So what you find here is that this is all the studies for lopinavir, these are all the studies for darunavir. You look at the number of events and total events. you weight it according to the number of patients in each study, and you come out with what would be an estimate here, which was significant. It was 0.95, and so that was a 5% difference in favour of combination therapy. And how do you then, so that comes along like this, we've seen before. And if you want to just quickly determine how you then translate that into an absolute effect, and it makes it clear of what's happening. So the relative risk is 0.95, a lower risk of viral suppression. The true effect is between 1 and 10%, so it's between 0.9 to 0.99. So we know the confidence is relatively narrow, but the true effect could be 1 to 10%. But the absolute effect is 43 fewer people per 1,000 will maintain virological suppression. So that we know then that, so that's 4 in 1,000 people on PI monotherapy will not maintain virological suppression. You can then translate that, is that important with regard to decision making? Okay? So you've turned your 5% significant value into something that you can say, all right, allowing 4 people to fail, is that important in terms of decision making? So clearly that was, but there were other things that we looked at. We looked at serious adverse events, we looked at drug resistance, we looked at viral suppression as well. And that was very good in terms of the quality of evidence. But for example, things like drug resistance, which PIVOT study was designed to look at, was very low evidence, largely because the precision, the precision of the estimate of that effect was imprecise, because the number of events in total in the trials was quite small. So you couldn't, so your confidence limits are going to be quite wide. So that's the reason why it was recorded as very low evidence. And so we recommend continuing standard combination ART as the maintenance strategy in virology suppressed patients. So overall, it was a strong recommendation C because it was moderate to very low in terms of the critical outcomes. Okay, so that's the way that we came to that conclusion. You could have argued, do we need to do that at all? But it was at a point in time where we didn't quite know whether, that our strategy was actually being adopted quite widely in terms of clinicians. So I'm going to just quickly go on to this one. So this is recommendations. We recommend, sorry, the only reason I've taken a TAF in there because that's taken from the 2016 update, it's a 2015 update, but it doesn't really relate to that. And I just want to read you through in terms of whether you think there is anything error here in terms of that. So we recommend therapy-naive individuals start combination therapy with those particular NRTI backbones, or sort of tenofovir FTC or TAF FTC as a preferred NRTI backbone, and that was graded 1A. We suggest a bacivir is an acceptable alternative NRTI backbone in therapy-naive individuals. In those with baseline viral greater than 100,000, it should be used with caution if there are clinical reasons for prefer it over alternative NRTI backbones. So it would suggest there's good quality evidence, but it's a 2A. We then go on to add this particular thing, that the caution regard baseline viral does not apply if bacivir is used with dolutegravir 2A. So are we saying in there, we're saying we suggest that Carvexa and dolutegravir, or bacivir 3TC and dolutegravir, is not a good combination. We know the quality of evidence is. What are we saying to a certain extent? Are we recommending it as a combination, or are we saying that we're not recommending it as a combination, and that most people would not want to follow that up? I'm being slightly pedantic, but in a way, it's a way of thinking, what are you trying to say when you make a recommendation in terms of making a strong recommendation or making a weak recommendation? So but the other thing that I want to go through with here, and you'll see another sort of handout, okay, which is a summary findings tables. And the reason, you can argue that's an error or not, maybe, but why did we come to the conclusion that at that time, tenofovir and FTC was better than abacavir and lamivudine? And so we'd gone through different outcomes. So if you take and look at the grade table in front of you, you'll see that right at the bottom, there is an assessment of virological failure, okay? And there's only one study, but it's a randomized trial. There were no serious limitations or inconsistency or indirectness or imprecision. It was a very good study, okay? And you can see that there were, and therefore the quality of evidence was marked as high and biological failure was marked as critical. But you can see that 45 fewer people per 1,000 on FTC tenofovir failed compared to abacavir 3TC. So what we're saying is that 4 out of 100, between 4 to 5 people out of 100, if you put people on Truvada, overall, not just we didn't look at whether this is appropriate for less than 100. We didn't stratify against baseline viral load, but we came to the decision on the basis of that recommendation because we felt that it was clinically relevant that between 4 to 5 people in excess experienced biological failure with regard to using abacavir 3TC if we take the total population altogether. We didn't look at the viral load subgroups. We took a decision right at the beginning not to do that. So at that time it was very controversial. We didn't know what the evidence would tell us, but when this was presented and it was represented as critical and you could translate it into a clinical effect, there was no discussion. It was basically all the discussion was put to bed because you had a critical outcome which there was high quality evidence for, which the estimate effect was sufficient to affect your clinical decision making. That was it. That was the supported your decision. So I say again, I come back to the fact that I think it's important to. You may not need all of those sort of things for every question you do, but for controversial decisions, I think it's important to look at that because it will take you through a process that then, at the end of it, it's very difficult to say, I disagree, because the evidence is in front of you. So I'm going to finish there in terms of the grading process, but I just want also just to quickly say to you, well, not everything can be graded. And so we introduced in all our guidelines what are known as good practice points. So these are recommendations based on the clinical judgment experience of the working group. They emphasize an area of important clinical practice for which there is not or nor is there likely to be any significant research evidence. Right? They address an aspect of treatment and care that is regarded as such sound clinical practice that healthcare professionals are unlikely to question it and where the alternative recommendation is deemed unacceptable. So it's not about, so for example, one of them was recommendation. We recommend patients are given the opportunity to be involved in making decisions about their treatment. Okay? You're not going to have any evidence with regard to that. No one's going to disagree with it, and therefore deciding whether it's a strong or weak recommendation is inappropriate because no one's going to argue. You're not going to say we suggest patients are given the opportunity or we recommend against patients given the opportunity because nobody would ever agree with that. Okay? So that was an example of where a good clinical practice point may be more appropriate than a grade recommendation. So I'm going to finish there, but in terms of just educational resources, the BMJ series in 2008 is a very good series. It's very easy, it's very readable, it's very easy to sort of go through, and so that would have been, I think, emailed to people about it. There's the, it's available through the grade working group. If you're interested in doing further modules and looking at the modules, the McMaster University developed 2 modules for the WHO, a more detailed module and a more introductory module that's available at that particular web address. So if you've got time, you want to go through and look more carefully about that, it will give you an understanding. So what I hope I've done is just give you an insight of how, what the principles of grade are in terms of how we reach decisions, not based on expert bias, but based on an analysis of the outcomes, what's important, and looking at the balance of preferences versus values. So thanks very much indeed. Do people understand that? So, Sarah, do you want any questions?
I have one question.
Yeah.
I think what's the PR monotherapy example you gave us?
Yeah.
I just wanted you to explain why it's 1C. Is it according to this, it's
Yeah.
low quality evidence, but you showed us quite...
No, largely because one of the critical outcomes was, so C is low quality, you're absolutely right. And I think probably we got it wrong. It should have been probably a 1B, right? Or even a 1A, because one of the critical outcomes was viral load suppression, and we showed very good quality evidence for that. So this is a learning process. I've identified 2 areas where there've been, you could argue about things, but you could argue that should have been a 1A because you identified a critical outcome where there's high quality evidence, and that was your priority rank, and therefore should have been 1A. Absolutely right.
It wasn't a criticism.
No. I think it's it's assessment. So the critical outcomes are the ones that carry the most weight when it comes to your quality of evidence. Okay, so you may have good quality evidence for other outcomes, but if your critical outcomes carry low quality evidence, then your quality of evidence is going to be low. They're not going to be high. Any other questions?
So the good clinical practice,
Yeah.
quite often do you give a grade recommendation?
You don't need to. Because I don't think you need to. Because what you're doing here in terms of,
One example would be,
Yep.
we discussed it, like use of a BHIVA in people with high cardiovascular risk.
Yeah.
So we did give it, we thought the evidence isn't strong.
Yeah, okay, so that's fine.
It's such an important area,
Yep.
as an MI, such a,
Yep.
life-threatening thing. We gave it a strong recommendation on based on low quality evidence.
But what was your recommendation?
Don't use a BHIVA in people with cardiovascular risk above X. With a good clinical practice.
Okay, that's
And
fine.
then it was given a sort of strong
Okay.
recommendation based on weak evidence.
You can give a good practice point and say, if you use abacavir, you strongly recommend people have a CVD risk assessment. Okay, that's a practice point. That's saying to people that before you put people on abacavir, you should say to people you must have a CVD risk assessment. That's a practice point. Okay, but if you're then saying that those patients with a 10% threshold should not be put, we recommend are not put on that, then you could argue that is not a good practice point. That should be based on evidence.
So so when I wrote the comments, the last iteration was...
I mean, you could say, the evidence for that threshold is not there, right? So it will be rated D, but you could argue that based the indirectness of the fact that you use, that's the intervention threshold for nice interventions, right? For other interventions, you could argue based on, you're not going to random. It's difficult, and I think I would use a grade recommendation for that rather than a good practice point. The good practice point is the fact that you've asked people to have a CVD risk assessment. Okay. Right. Okay. So the thing is, what you're asking people is to, before you go into bacavir, so you wouldn't say to people, recommendation is you do an HLA test, right? That, because you're not going to say, that's a good practice point. That is basically, you're going to say you must do it. You're not going to recommend against it, okay? So for example, if you're asking people to do a CVD risk, you could also say, we recommend against doing a CVD risk, right? Because that will be the alternative recommendation, okay? If in that situation it's clearly nonsense, then it should be a good practice point. But if you're saying that at a threshold of 10% we recommend, okay, you could say we recommend at 12% or 15% or 20%, okay? And so there is an alternative in terms of recommending against. There's a bidirectional value. So I always think with good practice points, you need to just reverse it and say, what would be the opposite? The opposite would be we recommend against this good practice point. And if that sounds plausible, then it shouldn't be a good practice point because there is uncertainty, okay? But where you're recommending something where the opposite is completely and utterly, ludicrous and it would never be recommended, even if there's no evidence, then that should be a good practice point. Is that clear? Yeah. Sarah.
When you look at, for example, monitoring guidelines,
Yes.
a lot of the trials, I'm not an expert,
Yeah.
a lot of the trials are all looking at, hard endpoints,
Yes.
trials, for instance, or suppression, whatever. But there's not probably, I don't know this, but what do you do when you're saying, I don't know, how people should measure CD4 counts or something like that?
Okay, but you can, if you say measure a CD4 count, you could argue, what is your outcome? What's your outcome? What are you trying, in measuring CD4 counts, what are you trying to achieve? you know, you may want to say you want to estimate the immune, you know, how robust the immune system, okay? But that may not be clinically important, right? In terms of, you know, for clinical decision making. So you could, I mean, I would always come back and, you know, and say there is in the BMJ series, there is one paper on what to do for diagnostic tests and interventions, okay? Now I haven't looked at it in detail, but that will give you some decision about how you might apply a diagnostic test. So for example, if I go back a little bit further, looking at resistance tests. Does resistance tests lead, you know, intervention, use of resistance tests, does that lead to better virological outcome, okay? And so that's the reason why people randomize people to have a resistance test or not have a resistance test, and they look to see whether the outcome in terms of virological suppression was not. So you could argue in that situation the test had a clinical outcome in terms of influence success. Now I would argue, you could argue that CD4 count doesn't do that at all. But you would argue your increase in CD4 count is not clinically, it may have been clinically important right at the beginning, but what now we know it's not that clinically important in terms of deeming success. So it will be maybe important, but not very important. So there is it's sort of getting a mindset to a certain extent in terms of saying, you know, and I think it's also important to understand that the recommendation, you can make a recommendation which is strong, but it's based on weak evidence, because clinically, the balance of preferences of outcomes suggests that this is what we would go down to. So I think, you know, when it comes to doing the guidelines for, you know, 2017, you've got some decision making in terms of whether you take out efavirenz, where you put integrase inhibitors. All those, I think you will balance out your preferences and your sort of desirable and undesirable outcomes, and how they then balance in terms of what the ranking of your recommendation is. All right.
Thank you very much. It's a question about ranking outcomes,
Yep.
which on the last guidelines I found it really difficult to do.
Yep.
Because I understand you can, you know, critical outcomes like viral failure,
Yes.
it's easy to rank that. But then when you go further down the list, we've just talked about
Yep.
CD4 counts, which are no longer as important
Yep.
as they used to be all this
Yes.
ago. So at this the question is, how do you rank those outcomes that have effects on quality of life?
Well,
So it might be side effect, might be something like diarrhea, for instance.
okay. Well, I would argue, you know, so that comes down to your values and preferences, okay? So, and it would come down to how the panel agrees. So you would say that diarrhea as a side effect of this drug is critically important, okay, right? Now, and that, you know, if the incidence of diarrhea was very high and it stopped people from taking the drug, right, then you would argue that was a side effect that was critically important because it basically leads to drug discontinuation, okay, right? And so hopefully you'll get agreement in your panel that will be ranked as high, okay? As critical, it will be ranked as critical, okay? So the incidence of diarrhea that leads to drug discontinuation is a critical outcome. Now clearly, you know, when you decide what your outcomes are at the beginning, you have already some understanding of what the drugs are, but what you're trying to do is define your outcomes by knowing the evidence, right? Because that is a confounder. You need to define the outcomes before you look at the evidence, okay? Because people could argue, well, you know, if we know that, if people knew that diarrhea was important, they could rank it down because they didn't want to see this drug being, not recommended, right? So it is the outcomes are really important. But I think that is a decision, you know, where there is a balance between, and that's where the community reps really are important in determining this, because they do help to bring quality of life into it. Now the problem quality of life has is that if you do a critical appraisal of a study, quality of life as an outcome is rarely used in randomized controlled trials. And so the quality of evidence you may then be looking at is often at cohort studies or and such like, not in randomized controlled trials. So often you may have a lot of evidence with regard to virological suppression or virological failure or drug resistance, but you may not have very much measured as quality of life. But you could have, for example, an extremely good drug that works really effectively, but the discontinuation rate is very high. So you could argue, is there a balance with the benefits and risks there? Should we make this a weak recommendation as opposed to a strong one? Jane? Yeah.
If you're deciding before you look at
Yeah.
your results, what evaluation you put on various
Yeah.
outcomes, is there any tendency for you to come into that with a bias based on what you already know and what you're experiencing?
No, I mean, I think you're absolutely right. Some people will do that, but we had that's the reason we have a large panel, right? Okay, and they would vote on it. Okay, so for example, some may put a greater emphasis on viral suppression at 96 weeks versus 48, or the incidence of drug resistance versus virological failure. Okay, and so that's why you have. I mean, so some of the outcomes for antiretroviral treatments are going to be very broad, are going to be very similar across different trials. Okay, but what I would always ask you to do is try and translate your outcome into what is important for decision making clinically. Okay, so if you're going to change a therapy, what information do you require to change that therapy? What's going to influence you the most in terms of decision making? Is it going to be the incidence of drug resistance? Is it going to be the side effect profile? Of course, overall, you have a series of outcomes which influences your decision, but you then have to be able to rank them and tell you what you think is most critical. It's difficult, but that's important to do at the beginning, because if you don't do that, then when it comes in the BMJ handout, there's also one paper on where decisions, where there's no consensus, how you reach consensus in terms of how you do that. And it's about taking tables and putting people's ticks and various things and what their preferences and values are. And then deciding, then you get a table which is very clearly, then you get consensus. But it's really, and you don't have, clearly, for a lot of the guidelines, and for example, the testing guidelines, there were very little evidence that basically determined. So it may be some of that will be an understanding of what, the outcome you want to do in testing will be largely is reducing the proportion who are undiagnosed. Right? There may be one outcome, okay? Or the number tested may be another outcome, or referral pathway for those that are positive. So there'll be very different things that you could basically look at in terms of what your outcomes are, but you'll have very little evidence supporting that, and therefore you will have to decide what your ranks are going to be, and therefore where you're going to put that recommendation.
Yes, that's a good point. The testing guidelines, because the populations, I'm going to suggest that maybe populations have changed now. So when you're working out your BHIVA question, so we used to have late diagnosis, but now that after the START study, recommended treatment starts at any CD4 count. So does that mean that in the testing guidelines the population changes from recently diagnosed to
No, because the
late diagnosis and
no, I think
where there are clinical presentations?
No, what the outcome for testing is you want to know whether someone's HIV positive or negative. That's what you're looking for, right? That's your main critical outcome. And so, so a good practice point was we recommend all patients are offered a HIV test, okay? Because the opposite to that is that we recommend against patients being offered an HIV test. And therefore, that's nonsensical. You're not going to do that. You're never going to come with a recommendation which is the other direction. But you may make a recommendation based on the prevalence of HIV in a patient population, right? So you could argue that if the prevalence is above a certain level, right, then you could make recommendation based on the prevalence in a population, right? Because you're looking at a threshold there, because you could argue we won't recommend in that patient prevalence, okay? But the idea of not offering an HIV test and saying we recommend against it, or we suggest, You know, it could be suggest, because it could be a population where the prevalence of HIV is very, very low, right? But I think in that you'll be looking at good practice points. So is that informed people at all? In terms of, you know, so it's just a reflection of what you're doing in terms of, so when you write guidelines, you always start off we recommend or we suggest. There's no other wording. Those are the two words that you start with. And you can either suggest against or just suggest for, recommend against or recommend for.